Hey guys, and welcome to European Medics. In today's episode we will be talking about altitude illness. Today's video will be kind of a deep dive, so strap in and do not be afraid to pause the video or rewatch parts of it if necessary. If you still have questions at the end, just comment down below or message me directly so we can go over it. Today's learning objectives are understanding the influence of altitude on the human body, understanding the pathophysiology of prominent altitude illnesses, including acute mountain sickness, high-altitude pulmonary edema, and high-altitude cerebral edema. We will also discuss treatment options and prevention methods at the end. Before we can talk about altitude illnesses, we need to understand how the altitude will affect our bodies. One of the most important factors in this environment is air pressure. As you can see, we have two gorilla medics here, one in the valley and one in the hilltop. Above the medic, you will see a graphical representation of the amount of air that weighs down on them. The amount of air above the medic in the valley is significantly higher than the amount of air above the medic on the hilltop. Since air has a certain weight, which is approximately 1.3 kilograms per meter cubed, the pressure on the medic in the valley is obviously much higher than the pressure on the medic standing on the hilltop. So what effect does the pressure difference have on our bodies? In this little diagram, we can see the alveoli in the lungs as well as the pulmonary vasculature surrounding it. At normal altitude, the air pressure or partial oxygen pressure on the vessel is pretty high and oxygen can easily diffuse in the pulmonary circulation and be carried into the heart. At high altitude, the pressure is much lower, which means that there is a lower partial pressure of oxygen, which results in less oxygen being transported through the membrane in the blood and then to the heart. So just to summarize, the lower air pressure at altitude will decrease the amount of diffusion pressure, which will decrease the alveolar diffusion of oxygen. That means that the body will receive less oxygen in the blood. This triggers certain brain centers to start reactions meant to fight this lack of oxygen. We will look at the specific mechanisms of this reaction now. So how does the body fight this lack of oxygen in the blood? Well, there's two main mechanisms for that. One is the immediate response and one is the delayed response. The goal of the immediate response is to compensate the momentary lack of oxygen. That means that a patient exhibiting this immediate response will show an increase in heart rate and vasodilation, which means the vessel diameter. This is an attempt of the body to widen the vessels in order to increase the surface area of the capillaries to enable better gas exchange between the tissues and the blood. Another thing we can observe is tachypnea, which means an increase in respiratory rate. Faster breathing will lead to more carbon dioxide being released from the blood into the air we breathe out. Carbon dioxide is acidic, so loss of it will cause alkalosis, meaning blood will become more basic. The body will compensate for alkalosis with frequent urination to get rid of the alkalic substances in the body. In the long run, the body will adapt to the low amount of oxygen by increasing the hematocrit, which is a ratio between the red blood cells that transport our oxygen and the plasma. This will be accomplished by increasing the amount of red blood cells and decreasing the amount of plasma in the blood. To compensate for the faster heart rate, the body will decrease the stroke volume in order to keep the cardiac output constant. The body will also increase the amount of 2,3-bisphosphoglycerate, which is a chemical that helps O2 detachment from hemoglobin, so it enables better oxygen exchange between the tissues and the blood cells. All of these mechanisms combined are part of the altitude adaptation. Okay, now that we have understood the physiology, let's jump into the diseases. The first disease that we will discuss can develop at altitudes around 2,500 meters above sea level and is called acute mountain sickness. AMS can happen where the body does not have enough time to compensate and adjust to the increase in altitude as we discussed previously. Patients with acute mountain sickness can present with symptoms of hypoxia such as headaches, GI symptoms, fatigue, and dizziness. A special tool that we can use in the recognition of acute mountain sickness is the Lake Lewis score. This score will help us determine what stage of acute mountain sickness the patient is currently in. So how do we manage acute mountain sickness? Well, the first step is to recognize it. Any illness that develops at an altitude should be considered some kind of altitude illness unless proven otherwise. Also, communication is very important, especially if you're the patient yourself. Communicate with your teammates, tell them that you don't feel well. Ascending further will definitely cause a worsening in symptoms. The next step is to stop at the current elevation. If there is no improvement within 24 hours, you should probably descend. There is also some pharmacological options. Acetazolamide and ibuprofen will help to get accustomed to the elevation and also lessen some of the symptoms. The next pathology is high-altitude pulmonary edema, which is much more dangerous than AMS and should be considered an evacuation criterion for your teammates. High-altitude pulmonary edema, or HAPE, develops because of a special mechanism that is present in our lungs. Usually, oxygen induces vasoconstriction, so tightening of the vessels in the tissues. In the lungs, however, lack of oxygen causes vasoconstriction. This mechanism is in place in order to prevent blood from going to areas of the lung that are not well oxygenated. The vasoconstriction will cause an increase in local resistance, which will redirect the blood to areas that are not constricted, meaning they are well oxygenated. That way, the body has a sustained source of oxygenated blood. So as we know, the low air pressure leads to hypoxemia, so lack of oxygen in the blood. Hypoxemia will lead to vasoconstriction in the lungs, and the constriction of the vessels will cause an increase in pressure. The increase in blood pressure will force fluid out of the vessels and will make them leak into the lung tissue. Free fluid in the lung tissue is called a pulmonary edema. So how will a patient with pulmonary edema present? Well, first of all, he will exhibit most of the symptoms that we could already see in acute mountain sickness. In addition to that, he will have significant respiratory distress, even to point of getting cyanotic, which means getting bluish skin from the lack of oxygen. He will have a persistent cough, dry at first, but later, as the edema gets more severe, it might produce a pink, frothy sputum. And he will also feel very tired and weak. As you have probably noticed, this patient is in a more critical condition and descent is very highly advised here. It might be necessary to oxygenate this patient if the blood oxygen saturation drops below 94%. Hyperbaric pressure bags are an option, however they're pretty bulky and heavy, so people don't like to carry them a lot. Since the edema is caused by vasoconstriction, we can give nifedipine, which is a pulmonary vasodilator. The last pathology that we are going to discuss today is high-altitude cerebral edema, also called HACE. The exact mechanism behind HACE is not totally understood yet, however it is very likely due to an increase in vessel permeability in the brain. That basically means that there is an increase in leakiness of the vessels in the brain. This causes the blood plasma to leak into the brain tissue just like blood plasma was leaking into the lung tissue in the high-altitude pulmonary edema. Symptoms of HACE can range from headaches, weaknesses, feeling sick, loss of coordination, up to even hallucination and decreased level of consciousness. A decreased level of consciousness is a dead giveaway and shouldn't be a big warning sign for you as a medic. Management of HACE should include the immediate descent and activation of the evacuation chain. We can also use dexamethasone to decrease the leakiness of the vessels in the brain, reducing the edema. As you can imagine, this condition can be very dangerous if not recognized early. So as you've probably seen by now, altitude illness can significantly impede operational readiness and should be avoided whenever possible. Probably the most important factor in preventing altitude illness is acclimatization. Also, the proper hydration is very important. Alcohol and tobacco will inhibit that. Some recommendations advise against intense exercise 24 hours before insertion into the area of operations in order to maintain normal tissue metabolism. As a pharmacological option, you can also pre-medicate with acetazolamide, which helps with preventing the respiratory alkalosis in the first place. So that was our take on altitude illness. I hope you now have a better idea of it. Thanks for watching, guys. I appreciate your time. Let us know your thoughts about this video in the comments below. If you have questions, feel free to comment, or you can also message us directly so we can help you out. Also, consider to like, share, and subscribe. It really helps us grow a lot. Thanks for checking in. Until the next one.